Good evening, friends, and welcome back to the Thursday evening teaching session brought to you from LTMMC San Hospital. We once again thank the authorities at San Hospital for allowing us to conduct these classes and to Alpha Max division of Alchem for giving a scientific grant to live webcast these clinics. The case today is being presented by Dr. Devina, which will be followed by a online discussion for about 20-25 minutes by Dr. Palni Raman on approach to lymphadenopathy. We start with the case, Dr. Devina.
Good evening, everyone. I'm Devina Datta. I'll be presenting today's case. So this is about a 9-year-old girl, third by birth order, born of non-consanguineous marriage, hailing from Andhra Pradesh, residing in Chembur, Hindu by religion, Teru by community, brought by mother with complaints of fever since 7 days, generalized weakness since 1 week, and increasing paleness of body noticed by mother since the last 4 to 5 days. History of presenting illness. Child developed fever 7 days ago, which is mild to moderate in intensity, relieved by medications, not associated with chills or rigors, active in febrile and interfebrile period, intermittent in nature with 2 to 3 episodes in a day. She also complained of generalized weakness and body ache at the height of fever. There was also complaint of sore throat, which is present since the last 5 days. Paleness of body was noticed by her parents, which increased in the last 4 to 5 days. For all these complaints, the child was taken to a local practitioner who prescribed symptomatic treatment along with antibiotics. Subsequent blood investigations were sent and child was referred to higher center in view of low HB. Parents also noticed the child was not gaining height adequately since early childhood, but had never shown the child to any doctor for the same. The patient was 2.5 kgs at birth and was described to be of normal length at birth by the parents. We don't have any previous height records. On inquiry, the child is able to fit in clothes worn 4 years back, and there has been no change in shoe size as well. Her activity and appetite is good. However, father gives a history of an unhealthy diet and poor sleep pattern. She is an average student and regularly attends school. Negative history. There is no complaint of breathlessness or palpitation, puffiness of face and limbs. This was to rule out any complications for the said low HB or anemia. No complaint of cough, cold, rash, burning, micturition to rule out causes of fever. No complaint of bleeding from any sites, vomiting of fresh blood. No history of receiving PRC transfusions in patient or family. No history of abdominal surgeries in the family. This was to rule out any cholecystectomy or any thing to do with cholecystitis. No complaint of yellowish discoloration of skin or eyes. No history of pica, worm infestations. No history of passage of dark tarry stools, and no history of pain in fingers, limbs, and abdominal pain. There was no history of constipation, lethargy, dry skin, hoarseness of voice, and cold intolerance. These are the negative histories was taken to rule out short stature. No history of recurrent LRTIs. No history of headache, nausea, vomiting, diplopia. No history of polyuria, polydipsia, and oliguria. This was to rule out the renal causes for short stature. No history of chronic diarrhea, bulky stools, and no history of any drug intake like steroids. Birth history, full-term normal vaginal delivery, 2.5 kgs, cried immediately after birth. There was no history of NICU stay. There's no history suggestive of hypoglycemia or any neonatal jaundice. Antenatal history, it was uneventful, spontaneous, it was registered pregnancy. Immunization history is not significant. She's been immunized till 5 years of age. Developmental history, she has developed milestones appropriately for age, and right now she's studying in 4th standard with good scholastic performance. Dietary history, she consumes mixed diet. However, child has had history of unhealthy diet, mainly comprising of outside junk food. Meals are not taken at proper times, and she does not have a proper sleep pattern as well. Her calorie intake is now 835 kilocalories as against 1,350 kilocalories, a deficit of 515 kilocalories. Her protein intake is 30 grams as against requirement of 32 grams with a deficit of 2 grams. Family and socioeconomic history, child has a seemingly tender, loving and caring family environment. Parents attain puberty at appropriate ages. There is history of rickets in older half-brother. He also had similar complaints of not gaining height adequate for the same. He was treated adequately and has now achieved adequate height. So anthropometrically, her height is 110. Yeah. So general, first slide. Hmm. Hmm.
So what are your thoughts on these presenting complaints? Fevers in 7 days and weakness in 7 days. Increasing paleness since 4-5 days. So the first question is this child absolutely all right 7 days back?
Yes, this is the history that was being
Okay.
given.
So what do you think?
Monsoon related illness like dengue, malaria, and B hepatitis.
So let's make a habit of going systematically. So let's not always jump to a final diagnosis. So when you talk of this, either you talk of this combination or you talk of one thing separately and then combine, right? So what do you want to do? You want to talk of the combination. So in dengue, do you get fever for 7 days and weakness for 7 days? So in dengue, do you get weakness from first day of fever? Normally, what happens in dengue? When does the child become lethargic or dull or weak? When does the child become that in late dengue?
Um, um, From the second week or third week is when the child starts complaining of weakness, mostly.
Not second week. What is the classic story of dengue? Come on, simple. Speak in the mic. High fever or low fever?
It starts off with high
High
fever.
fever. With body ache, without body ache.
With body ache.
Lasts for how long?
Roaming
4 to 5 days. Then what happens? Classic story. There can be variations, but what is the classic story? After 4-5 days, what happens to fever? Fever subsides. Then what happens?
The counts platelets are dropping.
So clinically, what happens?
Third spacing.
That is the time when the child runs into complications and starts complaining of lethargy, vomiting, whatever. So the point is not on day 1, on day 4, 5, 6, when the illness starts complicating. That's the story of dengue. So you said malaria, right? So fine. So malaria. Now, how will you dissect that further? Why do you think malaria? Because of fever and increasing paleness. Is that the reason? Yeah. So now can you dissect that further? So we've seen so many malarias. So do they become pale during malaria? Means today malaria started, tomorrow pale. When will that happen? For that, what has to happen?
Hemolysis.
How much?
Severe enough to cause paleness by the parent. Notice paleness by the parents.
So massive hemolysis has to occur for it to become so much pale that parents will notice. Now, if suppose it does occur, first of all, we have to think when it occurs, so much hemolysis. But if it does occur, what will happen to the hemoglobin from what to what roughly? What happens to the hemoglobin? It
drop.
drop ke crash.
Crash.
So crash mein when how will the child come to you?
The child will come with extremely sick.
Sick child. So in shock, the child will come in shock. And actually, I mean, except for the rare case of falciparum, so much hemolysis wouldn't occur on day 1, day 2, right? So there are problems calling it malaria also, right? So what else? Can you give us the details of the fever pattern?
Fever is mild to moderate, relieved by medications, not associated with chills or rigors, active in febrile and interfebrile period, and intermittent in nature.
So if you were to only look at the fever, what do you think?
It seems to be non-specific. Documentation is not available. Child is normal during interfebrile and febrile period.
Could be a
And
viral
lasting.
fever,
Hmm.
a viral fever, viral URTI, for example.
So basically, this is not bacterial.
Not bacterial.
And it is not erratic also to call it malaria. So if at all you are left with that group, maybe it's a viral fever, right? Now, generalized weakness, headache, body ache at the height of fever. So headache, body ache at the height of fever is fine. You can get in many fevers. What about weakness? So weakness at the height of fever, but when fever comes down, weakness is less.
Active in interfebrile period.
So which means what?
It's not a bacterial infection.
Yeah, what about the weakness? Which means what about that weakness? Huh? Temporary. So what does it mean? When there is increased demand on the body, there is weakness. Otherwise, the weakness is not so great. Right? So anything?
I think so. We have come to a conclusion that this fever is not a bacterial infection. Okay. Is it an infection at all? So if it's not a bacterial infection, is it likely to be a viral infection? We go by the commonness. Do you think it could be a viral infection? So which common viral infection go on for 5-7 days? That's the question. Most of the viral infections get better within 3-4-5 days. And this has continued for 7 days. Not that all viral infections get over by 4 or 5 days. Therefore, the common viral infections are possibly out. Okay, you may have a little long-lasting viral infection. Which viral infection lasts for a long time? Which viral infection lasts for a long time? Epstein-Barr virus. Okay, this is the way you start learning medicine. Not jumping to say, oh, this must be this must be that. No. Okay, so normally the viral infections have some common symptomatology like cold, cough, vomiting, loose stools. This child hasn't complained of anything at all. And to that extent, we are not even sure whether this is any infection at all. Certainly not bacterial infection. Viral infection we keep on card, but no clue to say it's a viral infection. Going on for 7 days without, but there is a sore throat for 5 days. Now, what does that mean? Did the mother say sore throat? Because sore throat is her interpretation.
Yeah.
So, what was the symptom?
She did say that the child was not eating well and she was complaining of pain while swallowing.
So now, how much is the pain? Is the child not able to eat? So all that is important. Is there a cough also with so-called sore throat?
No,
Okay.
she didn't complain about cough.
So now you start wondering, what is this throat? If you have a pharyngitis, you have a cough. If it's a tonsillitis, you have a pain in swallowing. So ask all these details. Okay, sore throat doesn't mean anything to us by this, but we are not sure. But if you say sore throat, at least there was some localization of some symptoms. And with 7 days fever, you could even have an Epstein-Barr virus coming in, because that often has upper respiratory findings and many other findings. So we keep on that. Now we come to paleness. So all that we have said is, it is unlikely a bacterial infection. It could be viral infection if we take that sore throat very seriously. Otherwise, it may as well be non-infective illness. Okay, so we are open on that. Now, what about that paleness of the body noticed last 4 or 5 days? Now, take a note of that. Which increased in the last 4 or 5 days? Paleness noticed. Paleness noticed itself is severe paleness. Then it further worsened. Looks something unusual. Okay. Increase means it's getting worse. Okay. So this possibly means that this child has been pale for a long time earlier. Okay. And the mother feels it has gone increasing, but how much increasing? Okay. Within 4 or 5 days, increase is not easy to make out either. So we'll only know that this child has got paleness for a long time. How much long time we don't know. Okay. And I think that's where we stay back. 2, 3 things I want to bring to your notice is one, of course, negative history we will talk. Don't give a long negative history. Okay. Negative history should be in the form of this. So I want to know whether there is any other symptoms like cold, cough, loose stools, etc., which could have said viral. Okay. But not every symptom that you know of is the negative history. So far we will stay put and let's see about those negative histories, and then we'll talk about the diet also that you mentioned. Let's see the next one.
Next.
Fine. Nothing much important. Okay. Yeah. Now discuss this part.
So you said no history of breathlessness, puffiness. So you're looking for complications of anemia.
Now remember that if breathlessness is there, do you think they will forget to tell you breathlessness? When they tell you paleness, when they tell you general weakness, they have forgotten breathlessness. So don't ask questions which parents will never forget. How can a mother forget breathlessness and talk of weakness? Okay, imagine that. So all that is not really right. Palpitation may be because the mother might have known, child might have known, and you might have asked. That is fine. Again, puffiness of face, limbs, parents will not miss it. Negative history should be such that is relevant to the case and the parents are likely not to report. Okay, so take a note of that.
Then cough, cold, okay, you said for localization of fever, so that's okay. Then bleeding from any sides, vomiting of fresh blood. So again, bleeding and vomiting of fresh blood are again big complaints which they will come up with. But like in a suspected bone marrow disorder, what you would ask is whether there were any red dots on the body. So petechial spots they might miss and take it as mosquito bites or something. So that is okay. Then receiving blood transfusions is fine. Abdominal surgeries, so provided later we are talking of hemolytic anemia or if that comes in discussion, it's okay.
And I think that is where it's important. When you said he was completely all right, we mean his weight was all right, height was all right, activity was all right, energy was all right, nutrition was all right. Okay. And now if you come back and say, no, he was not all right, then that history is not right. History should be growth. For example, if there is some congenital hemolytic anemia, the growth would be certainly not normal. So when you say, was he all right, it means many things that you look at.
The patient was symptomatically, symptomatically all right, as in the height and the weight were always below the norms actually for the child, but symptom-wise the child never had any complaints.
Correct. So what sir is explaining to us is, see, when you ask the parents, sab acha tha, their answer means to say no symptoms or no complaints. But when you are finding out sab acha tha kya, you are also finding out growth.
Okay.
So now if you got a history that he has always been short from early times, you got that history. So the same thing in exam you would present as that he had no symptoms prior to this illness, but has always been short in his growth. Okay, so you wouldn't use the words he has been absolutely all right before this. Now, why is short, we'll figure out later.
See, many systems involvement may not have a symptom. Classically renal. If you have a chronic renal disease, there may not be obvious symptoms to look at. If you have a renal tubular disorder, the parents may not much complain of burning micturition, puffiness of face, hematuria. No. If you have some malabsorption, there may not be obvious symptoms. So when you say you are all right, we are meaning many things. And otherwise, we start wondering whether all this has happened only in a short time. Okay, and I think that is important, right? Because now when you say no abdominal surgeries, the question asked is, why are you asking for a fever for 7 days and abdominal surgery? So you've already decided he has a spleen and they may have removed the spleen.
No, it could be. I was ruling out hemolytic anemias as well. So there's any history of cholecystectomy, for example, pigmentary gallstones or anything like that. That would be like indicative
right.
of hemolytic
See,
anemias.
I have no objection. What I'm trying to teach you is that instead of all that, you would have first started saying that no history of any significant symptom accompanied by present illness.
Okay.
Okay, let the examiner ask what significant symptom, cold, cough, loose stool, vomiting, you can blurt it out all that. Okay. And in that, surgery doesn't really come in. Because surgery, we have already made up our diagnosis. Okay. And to that extent, you're right. Now, pica, worm infestation may be fine because you have no passage of dark tarry stools, okay. Again, pain in the fingers, etc. You're looking at whether it's a sickle, etc. Right? Agree. So what we want to teach you is that, as he said first, are you sure he was completely all right? Okay. So the answer is not completely all right. You could have said he would asymptomatic. However, on detail asking the mother, she felt that he is not gaining weight, gaining height, etc. Right? Yeah.
Go on.
Right. Now, here on dietetic history, would anybody comment on what is something unusual in this chart? Read properly. I remember a cartoon where they have showed a healthy food, vegetables, fruits, etc., and unhealthy food, junk food. And below that, junk food, lot of calories. On the healthy food, less calories. Okay, junk food is full of calories, whether wanted calories or not, good calories, bad calories. So what do you pick up something unusual on this story?
The calories are less.
He's eating lot of junk food, still calories intake is less than required.
And anything else?
Protein requirement is
Protein is too good, but the calories are too little. In Indian diet of any kind, in any socioeconomic group, you may have enough calories but low protein, but rarely you have enough protein but low calories. Okay, so take a note of that. It could be, I'm not trying to find faults here, but examiner is going to pick up exactly that, right? Calories are too little. Okay. So if he's taking so little calories and so much of protein, then do you think there could be some problem in this child because of this kind of diet? So my question is, high protein, low calorie diet, what kind of damage you may anticipate?
Renal.
Renal. Okay. So much of extra protein as compared to calories, there could be. The old Atkinson diet for obese people to reduce weight used to be a lot of protein, and most of them reduced weight, but they died of a chronic renal failure. So take a note of that. Not very important in this situation, but take a note of all that, right?
Now, just again for thinking, history of rickets in older brother, he also had similar complaints of not gaining height and was treated adequately and has now achieved adequate height. So tell me, how does rickets affect height, and how did his treatment make him gain adequate height? Give a thought to that. So how does rickets affect height?
Mineralization of bone is affected.
So mineralization of bone is affected. So is longitudinal growth of the bone affected? Mineralization is of the cortex or the shaft, no? So means answer whether longitudinal growth is affected or no first. If yes, when? If no, why no? Come on, what happens to
The bones are weaker.
Ah.
The bones are weaker. And the child is they're not able to be as active as the other kids.
Okay.
So that could affect like the lifestyle. And during the growing ages, they're not able to gain as much height.
If he was short in height and now he has picked up, when is the growth fastest in childhood, height-wise? For example, how much does a normal infant gain in length from birth to 1 year? Birth is 50 centimeters.
Around
What is 1 year?
25 centimeters.
75. 25 centimeters in the first year. How much in the second year?
12.
Half of it. Okay. What is the important, and how much is the third year? Further half. Okay. Now, if somebody is short and on treatment has gained height, he must have been having rickets early in life. But if he had rickets at 4 years, he had already grown well, and there would not have been much shortness that needs to be corrected. So we might feel this child had probably a deficiency, vitamin D deficiency, and he got all right. Okay.
So basically, you would have said that longitudinal growth is affected in terms of, like you said, soft bones. So splaying of the epiphysis. So you lose length of the bone. Then the bones bend if there's too much of rickets. So again, you lose length. So, but all that will happen only in the first and second year, not later, right?
Okay. Which also brings us to some other discussion. Which rickets other than deficiency get well with treatment? They got well with treatment. So are there any other types of rickets which get well with treatment and thereafter no need of treatment? Means he is cured. So my other question is, what are the types of rickets other than deficiency rickets? So you have a dependent rickets, vitamin D dependent rickets, where you need a vitamin D for a long time in a higher dose. You have a resistant rickets, where a vitamin D doesn't work and you may have to give a metabolite to get out of the problem. And most of these problems don't get well forever. They would need a support all the time. Therefore, this must be a deficiency rickets, and we might take away that. But how can you relate this child's anemia to that child's deficiency rickets? Now imagine that child had a deficiency ricket. Let's believe that. And this child has anemia. Okay. Can two be together? So my question is, if an infant or a young toddler gets vitamin D deficiency rickets, what kind of anemia also is often accompanied by that rickets? Or in other words, I'm going to ask, if he's only on milk diet, he's not getting enough vitamin D. What else he does not get by only drinking milk?
Iron.
Iron. So iron deficiency and vitamin D deficiency go together because the same type of nourishment that is low in both. Okay, but that is besides. Okay, let's go further.
So what is your provisional diagnosis after history?
So, my provisional diagnosis on history would be that this is a 9-year-old girl, birth and developmentally normal, immunized till date. Could be a case of short stature with nutritional anemia, because going on her dietary history, she could be a case of nutritional anemia, is what I felt. Rest actually.
So short stature hasn't come out very prominently in the history. I mean, you've just said that mother feels that she's not growing much.
Compared to her peers, she's not growing much.
Yeah. So that you need to confirm that and look at that in more detail. And anemia you feel is nutritional. Can nutritional anemia cause short stature? Yes. So iron deficiency anemia, everybody is short.
Chronic deprivation of other nutrients as well.
So what you would say is pure nutritional anemia or pure anemia does not cause short stature. But if it is part of malnutrition, calorie, protein, minerals, everything, then there could be affection of growth.
So I think whenever you suspect nutritional anemia and iron, you must ask a little more details about the history. What kind of food normally you get iron enough not to lead to anemia?
Green leafy vegetables, for example. And if they make the food, like, for example, jaggery, green leafy vegetables, and if they make the food in iron vessels.
Good. So the point is, does he take much of an animal food that is rich in iron? Okay, you said mixed diet.
Mixed diet.
Might ask how often that mixed diet. Okay.
Okay.
So make a point. What are the sources of iron in a vegetarian food?
She said green leafy vegetables.
So we may have to ask all that, right? So that is the way you might supplement your impression that here, this is the child at risk of an iron deficiency anemia. What about B12? Who is at risk of a B12 deficiency anemia, diet-wise?
Vegetarians.
Vegetarians.
Again, vegetarian with poor milk diet. So ask all that. On the other hand, when you say this could be another type of anemia, which is a chronic hemolytic anemia, what questions would you ask? History of consanguinity? Okay, that's important. Ask the mother whether he feels the abdomen is a little distended. If this child hasn't had any blood transfusion and now he's coming at the age of 9 years with severe anemia, and if it's hemolytic, then the child better have a large spleen. Okay, severe anemia, untreated, might have short stature, abdominal distension, might even have some faces, but the mother may not pick up those faces to report to you, but short stature and an abdominal distension. Those two things might add to say, yes, this could be a hemolytic anemia, right? So now this will be an additional negative history.
Okay.
That negative history, mother says there was no abdominal distension. Okay, because you have thought of possible hemolytic anemia and you are talking about a possible splenomegaly or splenohepatomegaly, right? Right.
Okay, now let's look at the anthropometry.
But just before we go there, the story of anemia is only few days, no? Why are we not considering acute anemia?
We discussed it in the beginning, no?
It has been present, but then it increased, which the mother noticed were 4 to 5 days. So since it has been present, so less likely of being acute.
What about acute on chronic? I'll give you an example. This has got a chronic anemia, either deficiency or your hemolytic, whatever. We don't know that. And he gets on the top of it an acquired acute hemolytic anemia, autoimmune.
Autoimmune.
Is that a possibility? You're right. This is chronic, but chronic could be chronic or acute on chronic. And the story is acute on chronic. Okay, sudden deterioration. Though we did say to begin with that this 4 or 5 days is not called a sudden deterioration. But it could be acute on chronic. So could it be an autoimmune hemolytic anemia on the top of deficiency or whatever he has? How will you talk against it?
So acute on chronic hemolytic anemia, patient would be much sicker than he is.
May not be, but fever is there. So I would push to say that this is fever, and fever is an autoimmune hemolytic anemia. So something important, which she has already said in a negative history.
No drug intake.
Excellent. No jaundice. So acute hemolysis would have jaundice, and therefore you are right, this is chronic. But keep in mind that now that is important of your saying no jaundice. Okay. Both. You are also looking at a congenital hemolytic anemia with jaundice. I'm also looking at an acquired hemolytic anemia, right? But
Anthropometry height. Her height is 110.5 centimeters, which is below -3 SD. BMI is 14, which is between -2 SD to -1 SD. Upper segment to lower segment is 1:1, which is normal. Arm span is 111 centimeters, which is normal. And mid-parenteral height is 149.5, which is at the 10th centile. So according to the height, it falls below -3 SD, and it's below the 3rd centile as well, according to the chart.
fine. So this low height,
Excellent.
low weight. Okay.
What is the weight?
17.7, which is below
Below 3 SD.
-3 SD.
So these are typically a chronic renal disease. And chronic renal disease have shortness and anemia.
Chronic.
Okay. So now tell me, this looks like a chronic renal disease. Now, what is wrong in the history that can tell you that no, this is not a chronic renal disease?
There was no complaint of oliguria or polyuria
Okay.
which would suggest towards a urinary.
All right.
So what is the growth pattern in any chronic disease? Growth pattern as in relation of weight to height. In any chronic disease, will weight be affected? Yes. Will height be affected? Yes. Both will be affected equally. Height will be affected more. Weight will be good in chronic disease.
It would be equally affected.
So let's understand this forever now. Suppose there is a child, this 9-year-old child started with a chronic disease at 6 years. Suppose. So 6 to 7 years, whatever chronic disease he started with, what will be affected first? Weight or height? Weight. Then the chronic disease continues. So height starts getting affected. So when will height start getting affected? Say 7 years. So now at 9 years, he has weight affection of 3 years and height affection of 2 years. So which is more affected?
Weight.
So any chronic disease, usually the pattern will be weight and height both affected, but weight affected more than height. Okay? This is something which you have to remember. Now here, we always talk of height age and weight age. 110 is normal at what age? Height 110?
5.5.
6 years.
Fine. Fine.
Okay. And 17 kg is normal at?
We take 2.5 as normal. You have said that. So when it becomes 17.7, So he has gained 15 kilos. How long it takes to gain 15 kilos? Quick, 6
Around
kilos in the
2.
first year. And thereafter, 2.5 kilos per year. So we have 15 kilos to gain. 6 kilos in the first year, you earn 9 more. 2.5 per year. So another 4 years. So he should have been right there at about 5 years, 5.5 years. And the height is also similar.
So what do you find? Both are nearly same affection. This is never chronic disease. Okay. So this is something which you have to always pick up. Okay. Now, can you just explain on that graph what you have done? You must have you done right only, but
Yeah.
just explain.
So on this graph,
Speak in the mic. Make it closer to you, no?
so on this graph, so according to the age of the patient, which is 9, I plotted the height of the patient, which is 110, and it has come out to be below the 3rd centile here, which falls in the definition of short stature. And then I've calculated the father's height and the mother's height, and I've gotten out the mid-parental height, which falls between 149.5, which we take plus or minus 6.5. So that falls between 3rd and 10th centile here.
Then what have you done? No. So after plotting that range of mid-parental height, what is the next step to do?
That is a potential that the child can reach.
Correct. So how do you correlate that to today's reading? Extrapolate. So you will take today's reading to that, or you will bring that to today's?
Today's the height of as of now present one will just extrapolate to go there, reach there.
I don't think so. I think you have to do ulta. So what you have to do is that reading which you got, which you are saying is related to 3rd and 10th centile. So that 3rd and 10th centile is not important. Whatever is your number, you trace that backwards parallel to the existing curves. So effectively, this is your range. Now you trace this backwards parallel to the existing curve. Here, luckily, it is almost the 3rd and the 25th, or 3rd and the 25th. So you are actually on that curve, but you may not be on that curve. Say, imagine that your range turns out to be this. Then you have to trace it backward parallel to these curves like this, and then see whether where you go is your reading out of that curve or in that curve. That is what is important, right? Now, if it is in that curve, what does it mean? Which means, going by this child's height today, it is less than 3rd centile, but it is within that band. Then what does it mean? Familial short stature or constitutional delay. Now, how to differentiate between that?
In case of constitutional short stature, the final has to be more than the 3rd centile. But in case of familial, final has to be achieved, but it will be below the 3rd centile.
No, not necessary that constitutional you have to be more than the 3rd.
Then other features like delayed puberty in case of constitutional short stature.
No. Today, how will you make out in this child? We've said that it is within that band, but less than the 3rd centile, this child's reading. Now, today you have to decide, is it familial or constitutional? So what all will help you?
Height, velocity.
Height velocity today will be low only in both. Bone age. So how do you use bone age?
Bone age means, if a bone age is equal to chronological age, then it may be come in familial stage.
Very good. So one is you do bone age. Now, if the bone age is equal to his actual age, which is 9 years, that means his skeleton has grown like a 9-year-old. So it is familial short stature. If it's in that band, okay? And if his bone age is less or more than 9 years, can
But
you
the
ever get bone age?
But the chronological age will always be more than the bone age for
Exactly.
short stature.
So
So we take the height age as well.
no. So bone age less than 9 years. Suppose his bone age is 7 years. That means his bones, his skeleton has grown only like a 7-year-old, though he is 9-year-old. So that's the delay. That's the constitutional delay. So that's why you will say, no, he will grow up later. And before doing bone age, if you get this history in a parent, then you are almost sure clinically only that he is constitutional delay, even without doing the bone age. You got this point clear? Of course, now our subject is not falling in that band. He is below that band. So now we'll have to figure out what could be his problem. Right? Go ahead.
Then we also spoke about the upper segment and the lower segment. So that was to find out if it's proportionate or not disproportionate.
So when do you get disproportionate?
So proportionate could be in nutritional cases, or could be in growth hormone deficiency proportionate short stature. And disproportionate is anything there's short limbs and short trunk.
Yeah. So all the skeletal dysplasias and
even rickets can come in disproportionate short stature.
And mucopolysaccharidosis and all that. Right. Okay. Go on.
General examination. On examination, the child was conscious, alert, well oriented in time, place, and person. Pulse rate was 120 per minute, regular rhythm, peripheral pulses well felt, normal volume. RR of 24 per minute, BP was 90/60 in the right arm, pallor present, lymph node was present, which is 1, in right upper cervical region, soft in consistency, mobile, non-matted, 0.5 into 0.5 centimeter in size, non-tender, and no redness present. There was no icterus, cyanosis, or clubbing present. On head-to-toe examination, frontal bossing is present. There's no microcephaly, no midline defects, eyes and ears are normal, depressed nasal bridge, oral cavity is normal, no crowding of teeth. The child has bilateral talipes varus that is present. And SMA, according to SMR, she's stage 1, which is pre-adolescent. On systemic examination, on per abdomen, it is soft, non-tender. Liver is palpable, which is around 2 centimeters, soft to firm in consistency, rounded borders and non-tender, with a span of around 8 centimeters, and spleen is just palpable. Our other systems are normal. RS, air entry, bilateral equal clear. CVS, S1, S2 present, no murmur, and CNS, tone power, and reflexes are normal. My impression after.
Child is here.
Yeah.
No.
What?
You have a sheet?
No.
चप्पल निकालना बेटा.
कितना हो गया है क्या आ जाएगा ये बस वेरी गुड वेरी गुड examination pretty simple examination somebody even junior come on No, we come and examine the child.
Chalo, come. One more. Come.
No, you come on.
Okay.
Come on,
Okay.
that side. You do a general examination, we will do a abdominal examination. He will correct your findings. All right? Now. बच्चे को very good. Pull the mic for it.
Yes, sure.
You go on giving a running commentary.
Patient is examined in supine position. Patient appears to be comfortable. There is frontal bossing seen on head to toe examination. Frontal bossing seen.
Hold it close, Mike.
Frontal bossing seen. Pallor is noticed. Then no angular cheilitis. No angular cheilitis is seen. Okay. No cervical lymphadenopathy.
So related to anemia, what other general examination findings are important? Specifically related to anemia.
Build. Build.
Build. Build is not really okay.
Pallor.
Yeah.
Spoon shape. Koilonychia.
Very good. So platinichia, koilonychia. And what else? Hyperpigmentation of knuckles. Okay. So does she have that?
No hyperpigmentation of. There is hyperpigmentation. There's flattening of nails as well, so flattening
Okay.
here is present. Then
what else? On the face, what else? What all do you want to say?
Hemolytic faces.
So no hemolytic or hemolytic. Does she have?
no hemolytic facies, no ictus.
So frontal bossing is there. You all said. So then why not hemolytic faces? So malar prominence is the most prominent part of hemolytic faces, which is not there. Then icterus. Okay, good. Dysmorphism. Very good. Why don't you come and examine? Okay, good.
I think the examination starts first with appearance. Is he sick
Non-sick.
or he's not?
Non-sick.
If he's sick, is he acutely sick or chronically sick? So he's comfortable, not sick. Okay. That tells you that this is not that chronic renal or malabsorption. Many things are wrong. Right? So he's comfortable. He's happy. Okay. So he has a chronic anemia. Okay, he's not in failure at all, he's not sick, he's not in shock. So chronic anemia in a very comfortable zone. Okay, what about this? On examination, what is his nutritional status now? Do you think he has a calorie malnutrition? Do you think he has a protein malnutrition? Do you think he has a fat malabsorption, fat malnutrition, vitamin malnutrition? So my question is he chronically malnourished? What about calorie malnutrition? Looking at him, he has already told us about the diet. Do you think on examination he has a calorie malnutrition? Why do you say no?
Buccal pad of fat is well preserved.
So in other words, look at the subcutaneous fat everywhere. Okay.
So don't say buccal pad of fat because that is the last
That's the
to
last
go.
one.
So
Okay.
say in general, everywhere, arms,
So-
legs, etc.
So fair part, look at the folds. Okay. Fair subcutaneous fat. What does it mean? Enough calories. He may look small, he may look short, he may have small weight, but he is not calorie malnourished clinically. Does he have a protein malnutrition? What signs?
Hmm. No signs of edema.
So again, edema will be last. Before that, what else?
Raised discoloration of hairs and flaky pants appearance.
So hair changes. Then what else? You all speak
Dermatosis.
dermatosis.
changes.
Then
First, edema feet. Okay, first sign. Thereafter, skin changes, hair changes, mental change, all that. So no edema. Okay. Where do you look at for edema? Just show me how you test for edema.
2 centimeters of the medial malleolus. We'll press for 10 seconds and look for a peat formation.
Fine. So no edema, no protein malnutrition, no calorie. What about fat malnutrition? How do you test for fat malnutrition? Protein and calorie, you know well. What about fat?
Waist.
Dry skin.
Toad skin.
Signs of vitamin deficiency, vitamin A deficiency level C for Bitox.
signs of fat soluble vitamin deficiency.
But mainly the fat is calories also.
Yeah.
And a few fatty acids will have phenoderma. So possibly look for all that, right? And then the vitamins also, especially A, D, whatever you are. So here's the vitamin D deficiency, right? You agree? Here's the vitamin D deficiency. Frontoparietal bossing. Agreed? All of you agree? No, we don't agree. So here's the only sign is that, no other sign. So here's an early vitamin D deficiency, only frontal bossing. What do you mean by that?
So when do you see frontal bossing classically in vitamin D deficiency? At what age?
Younger patients.
Younger patients we see.
Yeah, infants. Exactly.
And really, there is no bossing, really. Bossing is, okay, there is no bossing, okay. But the point is, in rickets, if you see a treated rickets, the signs take time to disappear. And some of them may not disappear at all. So he doesn't have active deficiency rickets at all. First thing, he doesn't have that kind of bossing. But make a note, even if he had, suppose, some obvious frontoparietal bossing, it may not mean that it's an active rickets and the findings take long time to disappear, but he has nothing at all. So that much on that. What is your comment on the pigmentation? Look at the knees, look at all the fingers, toes, look at here, this. Okay. So I think he must be having an adrenal disease. Two causes of pigments, B12 and adrenal. Which of this you think he has?
B12.
B12, why? Just because he's anemic? Could it be without either of the two? And therefore you look at his father also, okay. This could be a normal phenomenon, nothing else. Okay. And it's not rare to see this kind of a knees looking hyperpigmented. Many children, when they go to school or so, they sit like this with the knees abut against the bench in front. So this is not really that. Certainly you look for B12. Do you think it could be adrenal also? Adrenal deficiency? So Addison's disease.
More will come in the adrenal crisis, Addisonian crisis. They will come more with this shock. Yeah.
And
Shock is acute adrenal
what about chronic
insufficiency.
adrenal?
They could come with hyperpigmentation.
So symptom like vomiting, not doing well. So this is not. Okay. B12 certainly you look at it. Of course, iron B12 often go together. Now do an abdominal examination. सिर्फ पेट देखेगा हाँ 1 मिनट शाबाश तो स्कूल जाता है ना अरे वाह होशियार है तो
Good.
first inspection.
So, first is inspection. Shape of the abdomen is normal. Umbilicus is it seems slightly lower down, vertical. All the quadrants move with respiration. Nose, no visible scar, sinuses, no dilated veins, no hemorrhagic spot, no visible lump. And I look for the hernial sites as well.
Okay.
In superficial palpation, there is no localized rise of temperature, no tenderness. That's a deep palpation. So in deep palpation, we'll go with the viscera palpation. So first I'll palpate for the liver. So palpation will start from the right iliac fossa. I can ask the patient to inspire if it's a bigger kid. Fastly. So with every inspiratory effort, I'll go down. And yeah, so it's palpable out here. So the height of inspiration, the edge of lever will touch the radial aspect of my finger.
Can you improve on palpation? You saw what he was doing. He said, let the liver touch his fingers. Okay.
Liver.
What does it mean? You don't dip your fingers. You, in fact, stop liver from coming. So you just keep it and let liver come and touch you. You don't go to the liver, right? Just do it properly. Yeah, so don't push. When you push, you're not allowing the liver to come down. Just
the softer the abdomen, the lesser pressure you have to give. So all that pushing is in those nephrotics with ascites where you are searching for the liver, right? Here it should be very minimal pressure. Okay. Basically, you just press this much.
see the fingers. He's not pushing in.
And you must keep all this close and you bend only at the MP joint. You don't do like this and you don't press too much. So bend at the MP joint slightly. Okay. So just listen. सांस लो बेटा जोर से. सांस लो. See, now it's already touching my fingers. Okay. So,
so where do we bend? Like
this.
Yeah.
I am flexing only here and that too. The angle of flexing is not like 90 degrees. It's 15-20 degrees because you're just pressing like this. Pressing just this much and then parallel to the costal margin, and then you're getting the liver here. I'm already getting the liver touching you. Okay. And then same is about the spleen. So you just bend here and you go slowly and it's already touching my finger here. Right? If you do this, then you will miss the spleen.
Right. But if you cannot palpate, then of course turn him on one side and then fish it out of that. Because the spleen has to come almost 3 times more.
So this spleen is easily palpable. So even without turning, right? Yeah.
Fine. Okay, good. Thank you. Thank you. So now they're going to give you a final diagnosis. You have liver and spleen and no faces and
No
short
faces.
stature. Okay.
So, 9-year-old girl, birth and developmentally normal, immunized till date, with short stature and anemia with hepatosplenomegaly, to rule out non-transfusion dependent thalassemia syndrome and nutritional anemia. These are my diagnosis after history.
So let's discuss. So for a moment, forget this child and tell me what findings you expect in a non-transfusion dependent thal syndrome. What finding do you expect?
Paleness will be noticed from long time, not just for 4 to 5 days. And liver, spleen, span will be more.
Liver spleen will be bigger. There will be abdominal distension. Liver spleen will be firm in consistency. What else? There will be hemolytic faces, no? Prominent. So what you're talking of is, this is, means here, what is the nature of the hepatomegaly and what is the nature of the splenomegaly?
Here we can think about, this could be thalassemia, like she mentioned that the child would have had anemia for a long time, but because of fever or any acute event, maybe there could be some induction of the.
No, what we're trying to say is, why are these thalassemias not transfusion dependent? What is the logic behind that? Why are they not transfusion dependent?
Because there's enough.
Body can compensate for the non-stress. When the body is not in stress, it can compensate for the demands.
Or there's enough extramedullary hematopoiesis. So there will
That's
be
the
more
point, na? That they are compensating by extramedullary hematopoiesis. So the extramedullary hematopoiesis should be very visible. So it is not so visible here, right? So that is why that is not a very prominent possibility, right? Now, if it is nutritional anemia, then how do you explain the liver spleen?
I can explain the liver.
Vitamin D deficiency can cause laxity of the abdominal, the muscles, hence some visceraptosis.
So see, again, vitamin D deficiency, you have to take it in the context of the age. Okay. So now suppose a older child or an adult gets into vitamin D deficiency. Will they develop laxity of abdominal wall? So laxity of abdominal wall is in infancy, if that time there is vitamin D deficiency, right? And visceraptosis, how will you reconfirm? In liver, it's easy. So liver span. So you have to be clear first with the liver span, whether liver is enlarged or not. So what is the span here?
For her, this child has around 10 centimeters of liver span.
Okay.
So nutritional anemia is severe enough to cause failure, but history doesn't correlate.
No, why are you bringing in failure? Is she in failure?
So hepatomegaly with
But
anemia.
hepatomegaly at the time of failure, no? If she is in failure today, then there will be hepatomegaly today. So there was no sign of failure today. So what else? What was the consistency of the liver?
She said. Firm.
Soft, but more of
Okay.
firm actually.
Yeah. So
It's
the point is,
firm.
moment you say firm, the examiner is going to ask you that it's abnormal. Okay.
Yeah.
And if you want to talk about in this child that the liver is not pathological, you say it's soft. Now the examiner says, I feel it's firm. You say, but I feel it's soft. That's right. So I'm not going to discuss firm liver at all. Okay, you are right. In fact, any chronic liver problem, which is not hepatocyte or biliary tract, but reticuloendothelial cell, may look a little firmish, but it's not firm. So sometimes soft to firm. Okay, but soft to firm means you are never wrong. Examiner doesn't like it. Might say, no, this liver is normal, span is normal. So that. So when you find that to call it thalassemia syndrome, you have a problem. Okay. Can it be thalassemia minor? It's a thalassemia syndrome. Then get away, no? Is that okay? Which fits in everything. You have a spleen, you have a liver. Okay. You have thalassemia. So what is your objection to that? They don't present with severe anemia.
Nor do they have hepatosplenomegaly.
Okay. So they don't have. So that is out of question. Okay. So it doesn't fit in. For nutritional anemia, the liver spleen doesn't fit in.
No.
What does it mean? This is a combination. Okay. What combination? So two things. Is it a combination of both? For example, can it be thalassemia minor with
It could be.
deficiency anemia?
Thalassemia could explain the spleen, and or thalassemia could explain the spleen, and nutritional anemia would explain why she's come with low with anemia.
No, but we are saying that basically the spleen is not big enough to call it non-transfusion dependent thalassemia, na? And transfusion dependent, so anyway she is not. Right?
So now we will take a course the other way around. He has a chronic anemia which looks like deficiency. But you got fever also for 7 days. So can you find the cause of that fever, worsening anemia? And that's what the mother says. That after 7 days of fever, she thinks last 4 or 5 days is looking more pale. So now call it deficiency anemia in a child who has now malaria. Get both together. Okay. So combinations, but not combination of two hematological disorders. That's unlikely. Okay. So it's not a thalassemia minor with deficiency anemia. We would rather call it deficiency anemia with maybe malaria, which is so common in epidemiology, right?
And what about the short stature?
That the short stature would be explained by nutrition. Nutrition would explain the short stature.
So nutrition, as in you'll have to clarify further. So nutrition and means today's calorie deficiency is causing the short stature.
Or over the years, maybe she has been not receiving enough nutrition, so that could be a cause for the short stature.
Now, mother told you that she's not been growing for
since early childhood.
Since early childhood. So she's noticed that height since early childhood, right? Now, today's height and today's weight, we said is proportional. So what does that tell you about the speed of her growth?
That's not chronic. Because the weight
is constant.
It's constant, huh?
The speed of the growth is constant. Otherwise, it would have been falling. So even though you don't have a growth chart, but you can make out that this is not a falling growth pattern. This is not a worsening growth pattern. So which means what? She's growing constantly and yet she's short. So which means what?
She's pathologically short stature. Like it's not just connected to nutrition.
It is not pathological. Patient is
So it's not
growing parallel to the growth chart.
could be constitutional or familial.
So the question is he a growth hormone deficiency? That's what he's trying to tell you. Growth hormone deficiency child is short. Okay, he's otherwise happy, comfortable. He has no other problem. So do you think he can be a GH deficiency? And that's where you get a story that he is not deteriorating in height. He's maintaining his height velocity as per the history. And therefore, it's likely to be constitutional or genetic. And that's what we discussed earlier. So that short stature and short weight and weight for height is normal. So that's his stature. And it is not related to any chronic disease. It's not related to hemolytic anemia. And it's not related to malnutrition also. So we will explain that by that, right? Do you have any investigations?
The investigations done were on arrival, complete blood count, HP of 3.4, MCV of 55.1, MCH of 15.2, MCHC of 27.6, and hematocrit of 12.2%. WBC 2,300, lymphocyte predominant, platelets of 108,000. On peripheral smear, it was hypochromic microcytic RBCs with lymphocyte predominant WBCs with mildly reduced platelet count.
Okay. So based on this CBC, what are your thoughts? First, tell me about the CBC and then correlate it with the your clinical findings.
So this is a picture which is suggestive of hypochromic microcytic. This could be suggestive of a nutritional anemia, most commonly iron deficiency anemia. It could also be a suggestive of a dimorphic picture, which could also be with vitamin B12.
Well, how do you say it's dimorphic? What is there to tell you this is dimorphic?
It could be not strictly. And there is pancytopenia as well. Not that much though.
No. So there's nothing on this CBC which is telling you that this is dimorphic. But now why do you say pancytopenia?
All the three cell lines are depressed, suggestive, along with a depressed reticulocyte count, which means hypoproliferative bone marrow, suggesting vitamin B12 or folate deficiency.
What you want to say is that though there is no evidence here, but if you take this pancytopenia with her low retic, whether that is indicating a B12 deficiency, that's what you're trying to say.
Actually, normally, if there was an iron and B12 together, MCV may not have been so low. One could have compensated for the other. Therefore, you would rather explain the low platelets and low WBCs with something else. And that is what we were talking about earlier. Could it be viral? Could it be malarial? Where you have a low WBC, low platelet. So that explains on that. Iron deficiency anyway should have had a higher platelet count. Okay, now here it's a lower, but also WBCs are lower. So this is not really a pancytopenia as we would push with B12 in that, but certainly we would have expected MCV to be merely 80, 90, closer to normal rather than so low. And therefore, possibly all that is malaria or viral. That is what started talking, right?
Can this be aplastic anemia? So first tell me only from the CBC and then tell me relation to clinical.
Retics are also low. The bone marrow is not working.
MCV would be normal.
So aplastic anemia is never so microcytic hypochromic. It is nearly normocytic, right? So MCV is too low for calling it aplastic. And then clinically, you know the clinical background of this child. So what is against aplastic? Yeah, liver spleen.
And not sick, comfortable. Then why retics are so low? So can retics be low in a deficiency anemia?
Come on. So retic is indicative of what?
Activity of bone marrow. Hypoproliferative bone marrow would give us a low retic count seen in megaloblastic anemias.
So the point is that if there is not enough nutrition, then even the bone marrow cells are not getting nourished.
No, raw material only, no?
And that's why the moment you give iron, the first thing you want to pick up is retics going up. Okay. So that's fine. What else has been done?
Iron studies were done. The serum iron is 122.5, which is above the normal range. TIBC of 334.2 and transferrin saturation of 36.7%. So these are not indicative of iron deficiency anemia. And vitamin B12 also falls in the normal range of 206. Then total bilirubin was done 0.3 mg per dl. SGOT, SGPT were 33 and 12. ALP was 269. LDH was 902. And BUN creat was 7 and 0.5. The course and ward after that. So we'll go with that. The child was given transfusion by 10 cc per kg. Deworming was done and worked up for the etiology of anemia. Stool RM was sent, which is suggestive of 4 to 5 RBCs, and occult blood was detected. In view of low reticulocyte count and values of other cell lines being on the lower side, bone marrow aspiration was done, which turned out to be normal. Post-transfusion HB was around 6.5 gram per dl. The liver size regressed, however, the spleen size remained just palpable. This was for the anemia. Then workup for short stature, CBC was done. ESR was 82 mm per hour. CRP was 2.3. VVG for ruling out acidosis is pH 7.38, PCO2 of 37.2 and bicarb of 22.4. Serum electrolytes 140 and 3.6. Serum calcium was 9.01. Serum phosphorus was a bit on the lower side, was 2.1. Vitamin D levels were 7.3, which were below normal levels. And PTH was higher, that was 81.9. The final lines.
So what does these investigations tell you?
The iron studies in B12. So they were actually So it was not suggestive because the transferrin saturation was not low. So normally we really don't look at the iron levels. We look at ferritin, we look at transferrin saturation. But because it was ferritin can be unreliable because in acute phase reactant we normally look at the transferrin saturation, which is not low. It was good enough for her. It was 36.7%, which is not indicative of iron deficiency anemia. And B12 was 206, which also fell in the normal range.
So now, having said this, what kind of anemia is still on the card? So is hemolytic still on the card?
It could be, but then total bilirubin and direct were in the normal range as well, was 0.3. And in hemolytic anemia, you would, with something which is not deficient, you would expect the retic to be a bit higher, which would not be 0.3, it would be more than 0.5.
And what about aplasia then? So at least temporary bone marrow suppression is possible. Whether temporary or permanent, we don't know. After you've ruled out the deficiency and all that. And hemolytic obviously is not fitting in. So then, but you said bone marrow is normal.
Bone marrow is normal, and we do have actually a stool RM, which was suggestive of occult blood. That could be that could be going in favor of some sort of bleeding loss, but then that would not explain the.
No, but the biochemistry wouldn't favor that. Na? Even if it's blood loss, then it has to be microcytic hypochromic. Na? And deficiency. So the iron chemistry should be fitting into that.
The bone marrow was done, which is normal. Yeah.
Fine. And you've done the bone age also.
Yeah. So bone age actually is 5 years, and height age for her is 5.5 years. So the bone age I got by the Tanner Whitehouse method. So that came out to be around 5 years. I took the carpal bones for her. So this could be my final diagnosis would I would want to rule out nutritional anemia and inherited or acquired marrow failure syndrome. Although by doing iron studies and B12, we've kind of ruled out any sort of deficiency.
No. So what did you interpret the bone age as?
So the bone age is 5 years. So that is less
Or
than the
a
height age.
chronological age of 9 years.
Yeah. So chronological age is more than bone age, which we do expect in short stature. And then we look at the bone age and the height age. So the bone age, so the height age is actually more than the bone age at this point, or kind of equal. So the child does have a potential to grow taller than
Not
she
that
is.
way. Not that way. So height age 5.5 and bone age 5 is considered nearly same. You don't call it as height age more than bone age, right? So when bone age is even less than height age, what group of disorders do you suspect? Endocrine disorders. Okay. But this would be taken as bone age equal to height age, which would mean what? Both are less than chronological age. Constitutional delay. So this is constitutional delay. And in constitutional delay, we said long back that when weight and height are proportionately affected, we said it's never chronic disease. So, and the child is fine. So it is constitutional. So this is fitting in with constitutional delay, right? So you have to call this constitutional delay and not anything else. Okay. Now, see, also remember that just like everything has a range, bone age has a range of approximately a year. So when you do a chronological, suppose a 9-year-old, and you get a bone age of say 8.2, you don't call it delayed bone age. 8.2 and 9 is okay, means it's within that range. So you have to look at the range of bone age also. It's not exact on the dot types, right? So these have to be taken as equal, and therefore you have to give the etiology as constitutional delay.
I think this bone marrow has been normal, but you have some kind of pancytopenia, which might be again explained by that fever, and it is possibly acquired transient bone marrow suppression, okay, of whatever origin. And I feel you must just repeat again after nutritional correction, and you should find the hemoglobin going up. And if that happens, then possibly no. I think what is important, you did all these tests because today is an era of evidence. And we already knew that the short height is not a problem. We knew that malnutrition is not a problem. So possibly in real practice, one would not have done any of these tests. But today you want an evidence, which means you have to be evidence of even being normal. Now, how can you have an evidence that you are normal? Okay, we almost did that. We said there's no liver disease, no kidney disease, no bone marrow disease. So we are ruling out that. I'm sure today evidence-based medicine want that. But we also want to learn when it costs. Even in China hospital, it costs. The BMC is paying for all this. So we need to look at, could we have avoided many of these tests? Okay, your biochemistry for iron, etc., are very valid. Bone marrow is valid, but other things may not be important. But good. So I think we end up saying that there has been a combination of diseases. There is some deficiency, there is something else. Something else is unlikely another hematological, but a transient hematological problem. That's why pancytopenia, etc. We can't talk of malaria or viral and leave it at that for a while and confirm it only on a follow-up, right?
Can you miss aplastic on bone marrow? So what have you done? Bone marrow aspiration or bone marrow biopsy? So what is the limitation of a bone marrow aspiration? Not common, but once in a while. So sometimes there are pockets of hypocellularity and pockets of normocellularity. So you can go wrong both ways. If you hit a pocket of hypocellularity, you may think this is bone marrow failure, though it's actually normal, and the other way around. So as Sir said, it is the response that will tell you over a period of time. And if there is persistent failure of response, then you would do a biopsy, refined biopsy, and then see whether it's really bone marrow failure or not.
Was bone marrow done after a blood transfusion?
Yes.
Must have been.
Yeah.
That itself could suppress the bone marrow temporarily. So take a note of all that. And for a while, I would say do nothing and wait to see the progress. That would solve the problem. But looks like there is a acquired transient bone marrow suppression, either infection doing it, which has disappeared now, or a transfusion added to it. And I think it should disappear by itself, right? Fine. But good presentation and good discussion, right?
Thank you.
Okay, we now move on to the second part of today's class. So Dr. Palni Raman will be talking to us about approach to lymphadenopathy.
Am I audible? Hello, Rajesh.
Yes, Dr. Palni, you are audible. Just one sec. Let us see you on the screen.
And with respect to the previous case, I've seen the thing X-ray showed the rachitic changes, number one. And number two, the child is a well child with a constitutional delay, number two. Number three, the hemoglobin of, that is MCV 55 with, but even though the hemoglobin was such low, sometimes what about the RDW and the total RBC count? We would have given a more, thrown some light, because TAL minor is very rare to have such a low hemoglobin, but usually the RDW will be normal and total RBC count will be high and the iron studies will be normal. Only when you do the HbA2 level, the Hb electrophoresis, we'll get the diagnosis. So in this case, the iron everything is normal. So even though it is very unlikely to be a TAL minor, or it can be a TAL intermediate too.
Yeah, but Palni, the TAL minor alone will not explain such a low hemoglobin.
Yeah, that except for that, the remaining thing, if we have the particularly the RDW values would have given us more clue, and the total RBC count. RBC count will be very high and RDW will be normal, perfectly normal for even such a hemoglobin.
Correct. Okay, I think you can start with your presentation on lymphadenopathy. Yeah.
My slide visible? Hello?
Yes.
Okay. First of all, thank everyone for giving me the opportunity. Respected sir and my dear colleagues and my dear students. And herewith, let us go how to approach a case of lymphadenopathy in our day-to-day daily practice. As sir was discussing about, the evidence-based medicine. Now, what is the best evidence-based medicine as per the latest guidelines says is, the best evidence-based medicine is, number one, evidence-based literature, number one, plus the experience-based knowledge, number two, and number three, the delivery to the needs and expectation of the patient. When all these three criteria goes hand in hand, then only it is the best evidence-based medicine. Not only literature, literature, along with the wisdom and knowledge, along with the final, as per the needs and expectation of the patient. All the three things should go together. That is the best evidence-based medicine nowadays. Okay. Now, going to the topic proper, lymphadenopathy is a very common finding in day-to-day children. In the vast majority of cases, it represents a benign etiology and self-limiting condition. Occasionally, a serious disorder like malignancy can arise. So only it causes anxiety among the parents as well as the caregivers, whether it could be a sign of cancer. That is the million-dollar question. The outline of my talk will be to define the lymphadenopathy, outline outline the evaluation, how I am going to go about when I meet a patient with lymphadenopathy, discuss the differential diagnosis with some cases, and recognizes the red flags and refer and carry on message. Before going to the basics, we all know there are a primary lymphoid system and a secondary lymphoid system. The primary lymphoid system is nothing but the bone marrow and the thymus where the lymphocytes are produced. Whereas the secondary lymphoid organs are the one where, particularly like for example, lymph nodes, spleen, tonsils, and mucosal lymphoid tissue, where these everywhere the lymphocytes study the invader and produce the appropriate antibodies. Roughly there are around 600 nodes in the body. Lymphatics carry these infectious agents, foreign particles, malignant cells, and unhealthy cells. They act as an intelligent filter, and they keep body free of these invaders. It is a school where everything is studied and finally produce appropriate antibodies. When something goes wrong here, whether there is any infection comes, it reacts in a way with the enlargement, or when abnormal cells, whether immunologically abnormal cells like malignant cells comes, they react in a different way, so that the lymph node can react for anything when in this thing. So in short, to define lymphadenopathy is nothing but enlargement of the lymph node. The threshold for enlargement varies with the age and location. Compared to adults, normally children will have plenty of lymph nodes normally palpable. So only the age also plays a major role in defining lymphadenopathy. And lymphadenopathy, again, it can be an inflamed or a non-inflamed. When it is inflamed, we say signs of inflammation is there, we say lymphadenitis. When it is not inflamed, we say lymphadenopathy. What about the normal size? Before going to the abnormal, we should have what is the normal size of the nodes in pediatric age group. About 4 to 8 years of age group, around 50% of the children, healthy children, will have nodes. With respect to cervical node, up to 1 centimeter is normal. With respect to epitrochlear node, up to 0.5 centimeter is normal. With respect to inguinal node, up to 1.5 centimeter is normal. This normalcy we should be aware of. Otherwise, we will be unnecessarily investigating these children. Why this age group is more prone for this lymph node? Why? Because like we know, like school children and preschool children are exposed to more and more infections, and they are more prone infections, and so immune system is so active in this age group. So these lymph nodes are normally palpable in this age group. That is the baseline. So only when we know these are all normal lymph nodes, then only we can go for the abnormal lymph nodes. So in short, any node above for the age, it is abnormal. Usually above 2 centimeter is an abnormal for any age group or in any location. Above 2 centimeter is the cutoff. So these are among the lymph nodes, the majority of the lymph nodes are present in the head and neck. Around 55% of the total 600 lymph nodes are present in the head and neck. And so lymphadenopathy is so common also only in the cervical region. So here we should be aware about what are the common nodes which we see in the head and neck, as well as we should know how to examine the head and neck. For example, we have to examine the horizontal group of nodes, starting from the submental group, submandibular group, pre-auricular, post-auricular, occipital. Then comes in the vertical way, I examine the gigolodigastric, upper deep cervical, and lower deep cervical or posterior cervical, come to the supraclavicular. So horizontal way of examining and vertical way of examining all the lymph nodes, from as we are being taught from the medical school days, we have to examine the lymph nodes from the back of the child. So we should know how to examine the child. As well as we should, at the same time, we should see what is the nature of the nodes, not only the size, because as I've already told, up to 1 centimeter is normal. and mobile is normal, soft is normal, and any mobile, soft up to 1 centimeter you node is normal in a child. Only when all these things are crossed upon, we say it's an abnormal. What about the other lymph node regions? We have supraclavicular, and any supraclavicular node is pathological unless proved otherwise. If the right side, it indicates a pathology in the mediastinum. If the left side, it is mostly in the abdomen. And we have the axillary node. We have the epitrochlear node. Sometimes we know epitrochlear node is very, very notorious, particularly in the case of infectious mononucleosis or a cat scratch disease. And inguinal nodes are very common in the school-going children because of the play and barefoot. They commonly have up to 1.5 centimeter node in the inguinal region. Popliteal node, when it is present, is definitely abnormal. These are the other lymph node areas we come across in the body. So in summary, these are the common areas on the drainage. Cervical node, head and neck, we know. Submental, submandibular, we know mostly the oral cavity and the face, mainly the cheek and the thing. Supraclavicular, I already told. Axillary and inguinal, we all know the thing. So apart from the nodes, we examine, whenever we come across lymphadenopathy, we should examine for the other lymphatic organs. As I already told, we have to see how is the tonsils, or the child is having snoring for mainly the adenoid tissue, and how is the spleen. So what are the other lymph node areas we should also examine? For example, in a suspected child, when there is absence of tonsils with recurrent infections, we know definitely it is abnormal. We are dealing with a case of immunodeficiency. So in the same way, when there is spleen is present along with the lymphadenopathy, we know definitely the lympho-reticuloendothelial system is involved. So we have to examine the other parts of the lymphatic system. Okay, now, so far I have dealt with about the basics of the where the lymph nodes are located, what are the draining areas, what are the other primary lymph node organs, secondary lymph node organs. Now coming to the clinical classification. When it comes to clinical classifications, very easily it can be divided into acute and chronic. Anything less than 2 weeks or anything more than 4 to 6 weeks. And when it comes to lymphadenopathy, it can be a localized or a generalized. We all know when more than 2 groups of nodes of non-contiguous regions are involved, it is a generalized. So if a localized lymph node can be an acute origin or a chronic origin, in the same way generalized node. So all these things have definitely more implications when it comes to the differential diagnosis. Acute node conditions are different, and chronic node conditions are different. The baseline is, when it comes to the lymphadenopathy, infections are the commonest cause. More than 50% causes of the lymphadenopathy are due to infections. And when it comes to infection versus non-infection, apart from the infections, we come across plenty of non-infections like medications, malignancy, and autoimmune diseases. So only here is the summary. So we can see the infection tops the list, which is the commonest cause for whether it is a localized adenopathy or a generalized adenopathy or an acute adenopathy or a chronic adenopathy. When it comes to the other causes, where we have the malignancy, we all know the leukemia, lymphoma, and everything. And the inflammatory disorders, we all know, like autoimmune disorders will present with the adenopathy, mainly generalized adenopathy. And many rare diseases are there, like Ikuchi, everything, plenty of things are, everything you can read in the books. Okay, going to the evaluation. As our professor always teaches, Amdekar sir always teaches, by a good clinical history and examination, we can come to a diagnosis in majority, 95% of the cases of acute lymphadenopathy. And in case of chronic lymphadenopathy also, up to 50 to 60% we can come to a conclusion with a good history and clinical examination. Only in case of chronic lymphadenopathy, when we are not able to come to the conclusion, we should look at the investigations. So let us see about the history. For example, age, how the age is important. We all know, when you come across a lymphadenopathy in newborn, we are mostly thinking about the congenital infection like torch infection. When we look at the lymphadenopathy in a school-going or preschool child, we know it's mostly the garden variety of infections are producing the reactive adenopathy. When we come across a lymphadenopathy in a school-going age is the notorious for the extrapulmonary tuberculosis like lymph node tuberculosis. When we come across the adolescent is the age group mainly for the Epstein-Barr virus and infectious mononucleosis. So based on the age, we can definitely narrow the diagnosis of the infections. In the same way, the malignancy also we can easily narrow down. Adolescents are more prone for Hodgkin's lymphoma, whereas below the 10 years or below 6 years, the non-Hodgkin's are very common. And in the less than 5 years, we all know mainly the leukemias and non-Hodgkin's neuroblastomas are very common in less than 5 years of age. So based on the age, definitely gives a clue. And also we also know like autoinflammatory disorders or autoimmune disorders like Kikuchi are very common in adolescent age group. We should not come to a diagnosis of Kikuchi in a 2-year-old or 1-year-old. And we should not in the same way diagnose a Kawasaki in an adolescent child. So we should know the age group and the importance of age with respect to history. Coming to the onset, duration, progress, as I already told, like acute onset, rapidly progressive, mostly it indicates a suppurative bacterial adenitis. Whereas a chronic and slowly progressive, we know mostly we are dealing with a case of tuberculous adenitis. Very slowly progressive, mostly by 6 months, 7 months, 8 months of presentation. We know that particularly the lymphomas like Hodgkin lymphomas are known to present over a period of 6 to 8 months also. So the onset, duration, progress gives a very valuable clue about the diagnosis. Coming to the nature of the swelling, is it painful or a painless? Painful indicates mostly we are dealing with the inflammatory, mostly an acute inflammatory or mostly an acute infective origin swelling, and mostly we deal with the acute infective adenitis. As I've already told, localized versus generalized. Generalized mainly is not so common. Usually localized is the most common thing. Coming to the history of recent infection, very, very important. For example, when you come across an inguinal adenopathy, when you see an inguinal adenopathy, acute, enlarged, suppurative tendular lymphadenitis, when you ask the patient any wound in the previous past, you can see the wound, that is healed wound will be present in the shin or in the leg also. Or in the same way, in a cervical, acute cervical lymphadenopathy, when you ask for the history, there would have been any previous history of ear and ENT infections or conjunctival infections or oral cavity infections. So because infections are the commonest, so we should ask for the history of infection in the drainage areas. The history of infection is very, very important. Coming to the constitutional symptoms, which are very important when it comes to the chronic lymphadenopathy. Whenever the chronic lymphadenopathy, for example, when you have a night sweats, even temperature and everything, we know the Hodgkin's will present with the constitutional symptoms. Tuberculosis in the older age present the constitutional symptoms, which are very, very important. And history of contact with TB, you all know, up to 2 years, we know the contact is very important. Now we are becoming more modernized and modernized. We start having a pets in the home with like a not more like Western worlds, but still exposure to cats and everything. The cats are more prone for, particularly where there is scratch, and cat scratch disease is becoming more and more common, like Bartonellosis, and everything is common. And medications, finally, not the least, sometimes some medications are notorious to produce generalized lymphadenopathy like phenytoin and INH. Anti-tuberculous drugs and anti-convulsant drugs are notorious to produce generalized lymphadenopathy. So such is the thing, the history is very important. Coming to the examination, as we have seen in this case also, first and foremost is the growth. How the child is well grown or not grown, because that gives a clue whether we are dealing with a well child or a sick child, and that gives a clue about the etiology, whether it is an acute problem or a chronic problem. And the examination of the nodes, particularly the size, as I've already told, more than 3 centimeter or more than 2 centimeter is highly pathological, and more the size, not the benign nature, more the serious nature of the problem. If the size is more than 3 centimeter and it is slowly progressing, the chances of malignancy are very high. So that is the reason the size is very important. Nature is very important. We will see in the next slide. And the location. And the location, as I've already told, for example, supraclavicular node is always a dangerous condition, dangerous node unless proved otherwise. So the location of the node also matters. Coming to the drainage area, we have to examine the drainage area, because whether it is a reactive node or not. Other lymphoid organs, I have told, we have to examine the spleen. For example, in the case of leukemia, we will be having lymphadenopathy with the splenomegaly, with the pallor. And finally, the systemic examination like skin and other areas, other system involvement, everything we have to examine properly. Only by these two things, we can easily narrow down the diagnosis. Okay, consistency, I have already told. If it is going to be a soft and mobile and shorty, it is a reactive. If it is going to be soft and fluctuant, it is going to be an acute suppurative adenitis. If it is going to be a rubbery, it is going to be a lymphoma. And it's a firm and hard, mostly you are dealing with a malignancy. So these are very useful clues on examination. Okay, investigations are rarely indicated for acute lymphadenopathy, but in contrast, they are very useful in subacute or chronic. But investigation should not like as a package. You should try to rationalize the as per the etiology. For example, any child coming with the 3 weeks of fever, with pharyngitis, with lymphadenopathy, you know what to do the investigation. You know you have to do CBC and peripheral smear, and mainly for the serology for EBV virus. So like that, you have to rationalize the investigation. Just like that, don't do a package of investigation. You have to investigate as per the problem arises. So that is the reason how a workup. So basic screen is a basic thing whenever you don't know what you are dealing with. So basically a CBC, peripheral smear, CRP and ESR will give a clue whether we are dealing with the hematological disorders, and LDH and uric acid will give whether we are having a lymphoproliferative disorders, and liver enzymes will give a clue about the mainly the viruses, the chronic viruses. And specific serology, then only we have to go after getting a clue whether we are dealing with the EBV, CMV, HIV, Brucella, Bartonella tox. All these things are notorious to produce generalized lymphadenopathies. We all know mainly the infections are the commonest cause of thing. And we'll do the Manto. But nowadays, the Manto is getting a lower significance. Even if Manto is positive, isolated Manto should not be treated as tuberculosis. Again and again, the baseline is isolated Manto positivity, even it is 15 millimeter. And if the lymph node is there, without cytological evidence and etiological evidence, we should not treat as a tuberculosis. Particularly now, the Manto is given a less significance. Chest X-ray, you all know, whenever you have a chronic lymphadenopathy, you take a chest X-ray to know whether there is mediastinal adenopathy is present or not, because the Hodgkin lymphoma is known to have a medullary lymphoma, non-Hodgkin's have to know to have medullary lymphoma, even a tuberculosis and sarcoid, you can have pick up a chest X-ray. Ultrasound is a very useful mean, which I will come later, and the CT MRI rarely, echo when you suspect a Kawasaki disease, and finally the FNAC and excision biopsy. These are the way we come across the investigations when you go across stage by stage, step by step. And finally, the baseline you should know, whenever there is a normal CBC and peripheral smear, it does not rule out lymphoma. Only leukemia is unlikely. Lymphoma is never ruled out by a normal CBC and peripheral smear, because it is mainly arises from the lymph node itself. Okay, ultrasound and lymphadenopathy, the short thing, and mainly useful to know whether the child is having an abscess or not, number one. Sometimes lymph node mimics can be easily picked up by the ultrasound. Even in the case of chronic adenopathy, we know whether it is a reactive adenopathy by a neoplastic adenopathy by means of if a good ultrasonologist will be able to differentiate a malignancy from a reactive adenopathy. So it is very useful if you are but it is it is a mainly operator dependent. So only it is concretely cannot be used, but definitely it gives a clue whether we are dealing with a reactive versus malignancy, particularly when you are dealing with a chronic. In acute, it shows whether separation is there or not. In a chronic, it shows whether you are dealing with a benign or a malignant. That is the specialty of ultrasound. The role of FNA, we all know FNA is very useful if it is positive. If it is negative, false negative is common in the pediatric age group. 50% of false negative is common, particularly lymphomas, because the abnormality may present in some corner. So like Rajesh was explaining, the abnormal things can be present in some, like in a bone marrow, the abnormality cells can be present in some corner of the lymph node. It can be easily missed. So the false negativity is more common in FNAC. So the ideal thing will be the excisional biopsy is the gold standard, one particularly if FNA is inconclusive and if you definitely say if a malignancy is thing. And finally, the red flags. So when you see such a red flags, more than 2 centimeter, increasing more in over a period of 2 weeks, persistent after 4 to 6 weeks, and no decrease despite 2 antibiotic trials, and absent findings in the drainage area, and abnormal chest X-ray, presence of supraclavicular node, and rubbery consistency, presence of constitutional symptoms. Definitely, when you have these red flags, directly you can go for an excision biopsy. No need to go for specifically step-by-step approach. Whenever you find a red flags, immediately you discuss with the oncologist and go further. No point in delaying the time, and go for the excisional biopsy and you will get the diagnosis. So red flags are very, very important. More than 2 centimeter and persisting more than 6 weeks, enlarging, keep on enlarging, and abnormal chest X-ray and abnormal supraclavicular node. And as I already told everything. Okay, the definitive test for ruling out the most clear diagnosis cancer is biopsy of the enlarged node. Okay. So now I'll go through the things which I have come across. over a period of about 2 decades, which I am actually having the documentation, the pictorial representation of various lymphadenopathies, which will be definitely, the pictures will speak more than the words. So you can see how the lymphadenopathy will present. Here is a child, school-going child with bilateral lymphadenopathy. And this is a very common, they are shorty nodes in the bilateral jugulo-digastric nodes are present. If it is in they can present in acutely or chronically. This is mainly a reactive cervical adenitis. This is the commonest node, is the jugulo-digastric node, bilateral node occurring secondary to viral infections. Whenever you come across it, this is the commonest cause, number one. And it will be mildly tender. It will be mobile. It will be fluctuant. It will be soft. And next comes the second commonest cause, is the acute bacterial lymphadenitis. You can see there is a firm with warmth and tenderness in the posterior cervical node, and you can see mostly commonly strepto and staphylococcal is the etiology, and the treatment is very simple. Over a period of 10 days, it will settle. And next comes here again a fever of post 3 days, posterior cervical node enlarged, warm and tender. You know it is acute bacterial cervical adenitis. It is it has written in the face. It is just acute adenopathies are very easy to treat. Here again, another acute adenitis. Here it is a submental adenopathy. You can see the submental thing is also otherwise known as Ludwig's angina. The etiology is, here is a pustular lesion in the chin, and this is causing after treatment, you can see. And whenever you come across submental or submandibular adenopathy, when there is oral cavity problem is there, you try to cover anaerobes. Normally, acute cervical adenopathy is due to strepto and staph. When it comes to the oral cavity, anaerobic cover has to be added. The drug of choice should be amoxiclav, not first generation cephalosporins. Here is again a child with a fever of 7 days duration. You can see a eschar, which is very common in our area, with adenopathy. This is a eschar with the posterior auricular adenopathy secondary to scrub typhus. It's a reactive adenopathy due to rickettsial infection. This we commonly come across because we have sometimes inguinal lymphadenopathy. Then we will search for the eschar. Eschar will be in the scrotum or in the penile tip. So that is the advantage of particularly using this reactive adenitis in rickettsial infection. Here again, another case. Here it is also common in mainly in the adolescent girls or school-going girls with the pediculosis, and they come with a lymphadenopathy, and the parents will come with the alarming thing. Sir, is it a TB? Is it a TB? Is it a cancer? They come with alarming. It is just a pediculosis, and treat the pediculosis. So again, so far I have told about all the benign acute conditions. This is not a benign acute condition. Whenever you come across acute lymphadenopathy, this one condition we always should have in mind. This is a lymphadenopathy with fever. You can see there is red and fissured lips. So whenever you come across with an irritable child with such a thing, you all know the diagnosis is written on the face. We are dealing with a Kawasaki disease. So in short, whenever you come across acute lymphadenopathy, these are the common things. One is reactive adenitis secondary to viral infection. Second is bacterial adenitis. Third is reactive adenitis to other infection and infestation. And fourth is never ever miss Kawasaki disease in an acute cervical adenopathy. Okay. Next, go to the next group. That is the lymph node mimics. For example, whenever you have a slowly growing mass, a neck mass or neck lump, they come with a neck lump. We think it's a lymphadenopathy. So this is a child with a chronically slowly growing mass presented to me by 4 months of age, having a mainly mass in the small, soft mass in the parotid area, that is the parotid or in the mandibular angle of the mandible. So this is a case when we did the ultrasound, it clearly showed this is a case of infantile hemangioma. When they asked the parents, this swelling was not there at birth and it was slowly enlarging. So like that, lymphangioma, brachial cyst, thyroglossal cyst and epidermoid cyst all comes as a lymph node mimics. You can diagnose, differentiate from a lymph node easily by ultrasound. So this is the second part, number 2. Now comes the third part. This is the coming to the chronic adenopathy. That is more than 3 weeks duration, 4 weeks duration. The first and foremost common is, this is a child, 4-month-old girl, swelling in the left axilla, progressively increasing, no constitutional symptom, no signs of inflammation, for all practical purposes, it is BCG adenitis. The most common chronic adenopathy in day-to-day practice is BCG adenopathy. So far in the 10 years, I would have seen around 30 BCG adenopathy. What you will do? Most of the time, mass turning inactivity. Around 25 cases settled without doing anything. Only 5 cases gone on to produce a BCG abscess, where you have to, the treatment is mainly you have to aspirate non-dependent aspiration by the needle. So BCG adenitis is very common in the when it will happen, particularly from the 3 months, maximum is 9 months of age. This is the few weeks to months after BCG. Due to inadvertent administration of the BCG by intramuscularly or deep, you will get this BCG adenopathy. It regresses spontaneously in majority of cases. Some may liquefy. For example, so this case, what happened? It has spontaneously ruptured, and finally the cicatricial, or if you do IND, it is a wrong thing. It can lead to a ugly scar, cicatricial scar. So this is a case of, and you will FNAC when you do, the AF will be positive, gene expert will be positive, and no point in evaluating in these cases as a tuberculosis. We all know for all practices, this is a BCG lymphadenopathy. These are the other cases of BCG adenopathy. It can present like a 2 to 3 nodes with a mated nodes like thing. And you can, when it is left, some cases can go for a BCG abscess. This is again a case, you can have a BCG abscess in the supraclavicular region, left supraclavicular. This is mainly due to the inadvertent administration of BCG in a higher up. In the deltoid region, the BCG was given. So the BCG adenitis was there in the supraclavicular region. So you can have a BCG adenitis here also. Okay. Now, okay. This is again, whenever you come across a BCG adenopathy in a well baby or a sick baby, you have to differentiate. This is a BCG adenopathy in a sick baby. Always see to that. Do the CBC. If the absolute lymphocyte count is less than 1,000, it indicates diagnosis written on the face. We are dealing with a severe combined immunodeficiency. So for all practical purposes, BCG adenopathy, CBC has to be taken into account. Particularly wellness of the baby has to be taken into account. See to that you are not missing a case of immunodeficiency. Okay. So this is the chronic adenopathy, commonest adenopathy I have told. What is the next common in our day-to-day thing? This comes the chronic cervical adenopathy, comes 4 to 5, that is a patient coming with a 3 to 4 weeks of accidentally detected or incidentally detected node in the neck, particularly the posterior cervical region is the commonest, and they come without fever, without any symptoms, they come commonly. How to proceed with? This is a $1 million question. Okay. So this is a child. So I'll go by examples. This is a 6-year-old child with neck swelling of 1 month duration. And when the child came, the FNAC was done, and a suppurative lymphadenitis was the feature, and received 2 weeks of antibiotics, no change. So as I already told, FNAC has a false negativity rate. Excision biopsy showed this child was turned out to be that is a necrotizing granulomatous lymphadenitis. What about gene expert? Gene expert was negative, smear was negative. But gene expert can be positive only in 30% cases of lymphadenitis. So definitely, so be careful. All the times gene expert may not be positive. In case of TB adenitis, only 30% chance it can be positive. So you can try FNAC for gene expert. If it is positive, well and good. If it is negative, go for that lymph node biopsy. This child presenting with a single node, that is a deep cervical node, over a period of time, without any inflammatory sign, turned out to be a TB adenitis. Okay. Now come here, there is a 4-year-old girl with no fever, no cough, no weight loss, 2 swellings, and not mated. This is a non-tender. This is a child with presenting with over a period of 1 month duration. They are malnourished child, not much malnourished, a malnourished child, where what happened? The FNAC itself showed the caseation and the CBNAT was positive. Here it is turned out to be a case of TB adenitis. So here you can see the 2 nodes, and finally turned out to be a thing. Here FNAC has helped this patient. Okay. Next comes. Here again another 2 children, 7-year-old child, another 2 children coming with a painless swelling over a period of 2 weeks. Here you can see a group of nodes, 3 to 4 nodes mated together. So previously first figure was single node, second was 2 nodes. Here you are seeing a group of nodes mated together. But all mated together nodes are not TB unless proved otherwise. Even it can be a lymphoma also can present with mated nodes. But still in our country, most common is tuberculosis. You evaluate for tuberculosis and all these cases turned out to be a case of TB adenitis. Okay, so it can present as all the three things, mainly to get sensitize yourself. It can present as a single enlarged node, it can present as a 2 nodes, or it can present as a group of nodes. And cervical node is the commonest area for TB adenopathy, and school-going age is the commonest age group for tuberculosis, extrapulmonary tuberculosis. We all know that is tuberculosis is common in infancy and adolescence. The only exception is mainly lymph node tuberculosis, which is common in 5 to 10 years of age. For example, miliary tuberculosis, meningeal tuberculosis less than 1 year, and all the primary complex less than 5 years, and reactivation tuberculosis in above adolescence, but 5 to 10 years is the commonest age group for mainly the lymph node tuberculosis. Here again, another case, this is other location. You can have a parotid node, chronic parotid node on investigation turned out to be a case of tuberculous lymphadenopathy. Parotid adenopathy turned out to be a case of tuberculous lymphadenopathy. Here is another case presenting with, there are 2 findings. There is dactylitis and there is a axillary adenopathy. We all know dactylitis in a child in India is known to be particularly TB is known for a musculoskeletal TB. That TB dactylitis is the commonest presentation. When you have both the thing, it is automatically proved it is tuberculosis unless proved otherwise. So far, I have shown cases of cervical TB as well as the parotid TB as well as the axillary TB. Even though axillary and inguinal TB are not uncommon, sometimes you can come across. So okay, so now come to the next case. Here it's a unilateral node and no history of TB in the family. X-ray test was negative, Manto non-reactive, FNSC smear was positive, but gene expert was negative. This combination, whenever you get, you should suspect, that is smear positive, gene expert negative, when you should suspect a case of mostly a case of non-tuberculous, non-TB, non-tuberculous mycobacterial lymphadenitis, like that is a tuberculous, that is what do you say, mycobacterium, scrofulation, everything. But take it for granted, even in institutions, everywhere, this is very, very, very rare in India. And this was one of the rare cases presented somewhere, which I have got it from them. And it is because wherever the TB is endemic, this non-TBM is uncommon. This is very uncommon. Even I got an expert opinion from my ICH colleague who is day in day out seeing plenty of TB adenitis. He told he has not seen a case of NTM lymphadenitis. So don't diagnose NTM lymphadenitis at the onset. It is a very rare diagnosis. Okay. Next, we will go to the next set of condition. Here you can see a child, 80-year-old child, well-nourished child, and a fever and neck swelling for a period of over a period of 2 to 3 weeks. Grandfather was suspected TB, no nodes in the other region, and FNAC was suggestive of granulomatous TB. But even though the child had a thing like a well child and ATT they were given, it was a no response. And this was a case shared by Dr. as a hematologist, that is Dr. Julius Scott. And what happened in this patient, and ATT 6 months, no response, and the excision biopsy turned out to be a Hodgkin lymphoma. Excisional biopsy is recommended whenever there is suspected malignancy, even if granuloma is present. So learning point is, whenever you are not convinced that it is not a case of TB adenopathy, go for excision biopsy. Excision biopsy is recommended for suspected malignancy. Malignancy suspicion should be based on the clinical judgment, history, examination baseline. Most of the time, my friend used to say the rubbery node is a very classical feature of Hodgkin lymphoma, sometimes mated lymph node also. So never ever miss Hodgkin lymphoma, because we all know it is a slowly growing tumor. Here is another patient who came with the report to me and had a cervical node which was very hard in the right cervical node, very hard and firm. And he came with the report. It is a case of metastatic carcinoma, and the metastatic carcinoma can be in the case of thyroid, or primary can be in the thyroid or in the nasopharynx. This is a case of metastatic carcinoma presenting as a lymph node, even though these are rare. And this is another patient presented with a 12-year-old adolescent with 3 weeks of fever and treated with 2 courses of antibiotics, no drainage site disease, vague constitutional symptoms. What to do? It is a chronic adenopathy. localized adenopathy, treated with antibiotics, no response. What are you going to do? Immediately, we know after the baseline investigation showed some amount of leukopenia with a normal ESR. There are also no clues. So when there are no clues, naturally you have to go for biopsy. This patient subject to do biopsy, provisionally diagnosed as a case of lymphoma, finally turned out to be a case of the biopsy told it is a case of histiocytic necrotizing lymphadenitis suggestive of Kikuchi-Fujimoto disease. These rare things can come as a surprise, but these are all lymph node biopsy diagnosis. These are all not clinical diagnosis. But as I have already told, but you can expect in an adolescent with a fever, with the constitutional symptoms, you can expect this diagnosis. So this is a case of Kikuchi-Fujimoto disease. So in short, whenever you come across localized chronic adenopathy, it can be infective or a non-infective. When the infective, BCG is the commonest, TB comes the next. Atypical mycobacteria are uncommon in our country. EBV can present as a localized bilateral cervical adenopathy. EBV can present. And finally, nowadays, cat scratch disease is coming up. Bartonellosis is coming as a chronic granulomatous adenopathy in children. So I'll ask for mainly the cat scratch or cat bite. And you can, particularly after the lesion, you can, after a few period of, after 2 to 3 weeks of incubation period, you can get the lymphadenopathy. And if the child is responding to azithromycin, it shows it is case of Bartonellosis. Non-infective conditions, as I shown here, it can be Hodgkin's, it can be a non-Hodgkin's, it can be metastatic, or it can be a neuroblastoma presenting cervical or a thoracic chain neuroblastoma presenting as a node, or rarely like Kikuchi-Fujimoto, some surprises like Rosai-Dorfman's and other very, very uncommon things you can get. These are the common causes of localized chronic adenopathy in our setup. Okay, come to so I have finished acute adenopathy, I have finished chronic adenopathy localized. Coming to the third set of condition, here is a 3-year-old girl, fever of 20 days duration with generalized lymphadenopathy and pallor. So we thought mostly I am dealing with a case of leukemia. What happened? The total count was 28,000 with the majority of lymphocytes. So we thought mostly we are definitely dealing with a case of leukemia. What happened? The platelets, the thrombocytopenia was there. The peripheral smear was abnormal and mainly showing plenty of atypical lymphocytes, around 64%. So it is a case of, turned out to be infectious mononucleosis. Usually infectious mononucleosis will be asymptomatic less than 5 years. Rarely you can come across such cases. That is fever with generalized lymphadenopathy and leukemia. You suspect leukemia, finally turning out to be a case of infectious mononucleosis. And better always try to get a oncologist, hemato-oncologist opinion. You should not never ever miss a case of leukemia in such a setting. So this is a case of, there is a infectious mononucleosis. Okay, coming to the another case, here is a 5-year-old male with high spiking fever over the past 6 weeks with intermittent rash. And rash at the height of fever, you all know automatically with the history and you know the diagnosis. Hepatosplenomegaly and lymphadenopathy was there. Generalized polyarthropathies was developing later. And when you look at the CBC, it shows the highly inflammatory markers, neutrophilic leukocytosis with thrombocytosis, with markedly raised ESR. With this combination, there is no need for biopsy or anything. You know it is definitely a case of SOJRA. But this SOJRA is a diagnosis of exclusion. Try to not to diagnose SOJRA in the first week, second week, third week. You should try to diagnose only after a period of 4 weeks or 6 weeks. Don't try to diagnose SOJRA in the first week or second week. This is a diagnosis of exclusion. It is not so common. Okay, next. So when it comes to the chronic generalized adenopathy, again, infections are the common. Coming to the infections can be anywhere from the EBV, it can be CMV, it can be HIV in a malnourished child. So always try to do the serology for the HIV or a toxoplasma, or in a PU child, it can be a case of brucellosis or it can be a Bartonellosis. All infections can present as a chronic generalized adenopathy. When it comes to non-infections, we all know leukemia will present. Lymphoma, particularly Hodgkin's, will present, and the rheumatological disorders, we all know any disorders are immune dysregulation. Whether it can be autoimmunity or it can be a neoplasm or it can be a lymphoproliferative disorders like ALPS, we can present with the case of generalized lymphadenopathy and as well as sarcoid. And finally, not the least, the medications. So all these things we should consider because the textbook uses plenty of causes, but these are the common causes which I have selected and try to portray you so that you won't miss in your day-to-day practice. So coming to the final flow chart, how I go about whenever I come across an enlarged lymph node. First step, after history and physical examination. That is the basic step where you come to a plenty of diagnosis. Try to find the red flags. If the red flags are there, discuss with the oncologist, rule out malignancy straight out. Don't delay don't delay. If the diagnosis is obvious, like as I have told, acute reactive adenitis, acute suppurative adenitis, and everything, is immediately treat the condition. No need to do anything. Treat the condition. If the diagnosis is suggestive, for example, features suggestive of infectious mononucleosis, features suggestive of Bartonellosis, try to do the specific investigation, come to the conclusion, I am dealing with this condition. Okay. You do the specific testing, but you are not able to, then what to do? If you are not able to come to the specific diagnosis, if it is an unexplained adenopathy, whether it is a localized adenopathy, what to do? Consider a short course of antibiotics, either 2 weeks of antibiotics, definitely 2 weeks of antibiotic, not a 1 week of antibiotic, 2 weeks of antibiotic covering mainly the streptococcus and staphylococcus. Sometimes you can add azithromycin if you suspect cat scratch fever, and add particularly oral cavity areas. And if you are having submandibular area, add anaerobic coverage also. 2 weeks of antibiotic, mainly for strepto, staph, and anaerobes, as well as when you suspect cat scratch, you add azithromycin. Give these antibiotics. Then you see, then you go for no improvement. What you do? Along with the generalized also, you do the basic test. As I've already told, basic screening test and specific test and X-ray test, and exclude mainly the basic things by FNACR thing. Again, finally, you are not able to come to the conclusion. The answer is biopsy, biopsy, biopsy. The excision biopsy is the final word whenever it comes to lymphadenopathy. That is the word. Now you should be clear. First step is rule out the red flags. Second step, treat wherever the diagnosis is obvious. When the diagnosis is suspected, treat, try to rationalize the investigation. When you are not able to know anything, then you go step by step. So carry on message is, lymphadenopathy is common. Vast majority is self-limiting. And majority are acute lymphadenopathy. In the past 15 years, when I look at my database, I had around 650 cases of acute cervical lymphadenitis. How much? 650 cases. Whereas chronic lymphadenopathy, hardly 20 in case of over a period of 10 to 12 years. So acute lymphadenopathy is the commonest, but which won't come to the institution. Only the chronic adenopathy will come to the institution. When it is a localized or a generalized, you go across step by step. Occasionally, it may represent a serious disease, which we should never miss. A thorough history and examination, careful observation, and appropriate investigation should help to decide which children require a biopsy or a further treatment. In a well children with a localized, non-supraclavicular, and no concerning systemic features, a period of observation of 4 to 6 weeks is usually the most appropriate management. Don't jump for aggressive investigations, invasive investigation. You can wait for 4 to 6 weeks. Whenever you have, as I've already told, it is a benign thing. You can wait for 4 to 6 weeks. Excision biopsy remains the gold standard for sampling of the enlarged lymph nodes. Thank you. Thank you, one and all. I'm ready to answer the question. Thank you very much.
Thank you, Palni. That was an exhaustive discussion on lymphadenopathy. Any questions from anybody? Okay. Thank you, Dr. Palni. So I think there are no questions as of now. I'm sure they will see this presentation again on our site and go through it again and revise the topic. So thank you once again. Thank you to all our online viewers and our other colleagues and faculty members who are there online. And we meet once again next Thursday at 6 p.m. Thank you.
Thank you. Thank you, Rajesh and Sir.
Thank you. Thank you.